Welcome back, ladies and gentlemen. Um, these videos are uploaded to my YouTube channel, Dr. K12, in case you were wondering. Feel free to subscribe. This is a channel in which I upload once weekly brief videos, sort of sharing my experience in medical training um, and also a career in medicine. I try to sort of unveil the silver lining in a career in medicine and bring out some of the positivity. Um, so they're sort of short, fun videos. Let's move on to the electrical axis of the heart and determining the axis. So before we start talking about the electrical axis of the heart, it's important to realize or try to visualize rather how the heart sits within the chest and the heart's anatomic position within the chest. So if you look at the CT scan um, cut over on the top right of the screen, you can see that the right ventricle is the most anterior chamber of the heart. And the heart essentially lies on its right side and it's rotated posteriorly a little bit, which brings the right ventricle, the free wall of the right ventricle anteriorly. Sometimes these come up in board questions where they give you, for example, a patient who received a stab wound to the chest and they ask you what structure of the heart is affected. They may say that the patient was eating a piece of chicken and the chicken bone got stuck in their esophagus and perforated through and they developed cardiac tamponade, and what structure was affected, which would be the left atrium. Or for example, the patient presents with dysphagia, all the workup, including EGD, everything else is normal, and you get an echo and there's a mass. What chamber is it in? It's the left atrium. It's a left atrial tumor that's compressing on the esophagus, so on and so forth. So the left lateral border of the heart is the left ventricle. That's easy. The anterior border is the apical right ventricle. The right lateral border is the right atrium. As I said, the heart lies on its right side, which brings the right atrium to the rightmost lateral border. The left atrium is posteriorly, and I gave you a couple examples with the esophagus. And then inferiorly is the apical posterolateral free wall of the left ventricle. So in terms of determining axis, there are four different general axes, or axes rather, that the heart net direction of current can fall within. So anywhere from 0 degrees to positive 90 degrees approximately is traditionally been taught as being normal axis, and that's shown in the green color. Left axis deviation is from 0 degrees to negative 90 degrees approximately. Right axis deviation is from positive 90 to about positive 180. And then we have what's called the extreme right axis, which is the top right axis. And again, this is a representation of the net direction of electrical current within the heart. It's not that the heart is rotated necessarily, although that can have an impact on the axis of the heart, the actual positioning and how it sits within the heart, and we'll go over that. But this is the net direction of current, and the amount of voltage, if you want to think of it that way, that is being pulled to one side because, for example, there's hypertrophy of the left ventricle, so there is more electrical activity and voltage being pulled towards the right side, so the axis shifts because the net direction of current shifts because of that voltage. And traditionally, it's been taught that we use two leads, limb lead 1, which is across the chest, across the top, and AVF, straight down towards the feet. And if you remember, if we go back to the first few slides of the PowerPoint, when an electrical current is traveling towards a lead, we have a positive deflection on ECG. When it travels away from a lead, we get a negative deflection on the ECG paper. And it uses essentially those two simple concepts. So if an electrical current is going down towards the feet, and we have a positive deflection in AVF, then we know it's going down towards the feet. It's confirming that essentially. If AVF shows a negative deflection instead of a positive deflection, then we know that that current is not going down towards the feet, and it's going the opposite way. It's going away from the lead, away from AVF, so it's going up. towards the head. And similarly with limb lead 1, if electrical current, um, or let me put it this way, if there's a positive deflection in limb lead 1, it means that the electrical current is going towards the lead, so it's a positive deflection on ECG. If the electrical current is going away from limb lead 1, which is to the left, and it's going away from it towards the right, then we have a negative deflection. And so we can use these two leads to help us determine what the axis of the heart is generally. There are several caveats to it, and we'll go over that. But the two thumb technique is what essentially we can use for limb lead 1 and AVF. So if it's positive in 1, it means the electrical current, the net direction is to the left. If it's positive in AVF, it means it's down towards the feet. So if it's to the left and down towards the feet, it falls within 0 to positive 90 degrees. So it's within the normal axis. So taking it one step further, you may be asked to determine what the actual degree is for the axis of the heart. And this goes back to this drawing here, the schematic showing all of the degrees from all the limb leads and the augmented leads with a one confluent point of, or 1 point of confluence rather, for all the leads. So one common denominator, which is in the center of the chest. So if you're, and again, you should be able to draw this from memory. It's very simple because all the degrees are about 30 away from each other. So they may ask you, they may give you a question with a 12-lead EKG and say, what is the exact axis number? And you can determine that by 3 simple steps. So first, locate the axis quadrant as shown on the previous slide using the 2-thumb method. Then find the limb lead or augmented lead that is most isoelectric, meaning that the positive component of the QRS is just as big, or I guess that's the best way to say it, just as big as the negative component of that QRS. So it has a positive deflection and a negative deflection, and they're equal essentially, and that's isoelectric. So find the most isoelectric lead, then add or subtract 90 degrees as needed by trial and error to fall or land within that original axis quadrant that you determine in step 1 with your 2-thumb method. So let's go through some examples. Let's go through example 3 first, and I think that's the more interesting one. So you determine, they give you a 12-lead EKG, and using limb lead 1 and AVF, you determine that it's a right axis quadrant. How did you do that? So limb lead 1 on that 12-lead EKG showed that it had a negative deflection, so we know that instead of the current going to the left as limb lead 1 is going, it's going to the right. So we know it's going to be a right axis quadrant, and we also look at AVF to make sure that it is a right axis and it's not an extreme right axis, the top right upper quadrant. And so AVF has a positive deflection, and so we know it's to the right and down, so it falls within the positive 90 to positive 180 within that quadrant using the 2-thumb method. Then we look at the EKG, and let's say the most isoelectric QRS is within limb lead 2. So we find limb lead 2 on our graph shown here, and we can see that it's over here at positive 60 degrees. Then we use our trial and error method by subtracting and adding 90 degrees to see if we can fall within that right axis quadrant over here that we determined with our 2-thumb method. So if we subtract 90, we go back up to negative 30. Negative 30 falls within the left axis deviation quadrant, so that's not it. So we go back to 60, and now we add 90 degrees, and we fall within the positive 150 axis quadrant, and we fall within the right axis quadrant that we determined with our 2-thumb method at positive 150. So this is our axis degree calculated exactly. Examples 1 and 2 are similar. I'll leave that for you all to go through and practice. So there is a caveat to determining axis, and this is the slide that sort of touches on that. Now, normal axis is often taught, traditionally taught by many texts, to be 0 degrees to 90 degrees. That's typically done for simplicity and so that we can use the 2-thumb method. clinically to quickly determine the axis. However, the general consensus amongst many, and I think this is amongst experts in the field, and there's a lot of data behind this and literature behind this, that normal axis is actually from somewhere between negative 30 degrees to just past positive 90 degrees, approximately positive 100 degrees. So if we were to use AVF and we take a perpendicular line with AVF, that gives us limb lead 1. So it starts at 0 degrees, and we're missing the population of patients who have a normal axis, but they're up to negative 30 degrees. However, if we look at um, limb lead 2 and we take a perpendicular line, we make a perpendicular line to limb lead 2, then that takes us all the way to negative 30, which is AVL. So that's why limb lead 2 and limb lead 1 are the best leads to use to determine our axis. And it's the similar kind of method. You can also use the two-thumb method with it, I think. But if generally, if you have a positive QRS, positive deflection QRS in limb lead 2, we can say that the net direction of the current is going in the same direction of limb lead 2, and that's how the heart sits within the chest, so it's probably a normal axis. If you look at your AVF and it's negative, or if you look at your limb lead 1 and it's negative, then that can suggest that perhaps there is a left axis deviation or a right axis deviation as well. But typically just looking at limb lead 2 will give you that information. So what can cause axis deviations? There are multiple causes for this, and this is a normal sinus rhythm because different arrhythmias can cause different axis changes. So in normal sinus rhythm, what causes left axis deviation? The major cause of it would be left ventricular hypertrophy. So hypertension, hypertensive cardiomyopathy, hypertrophic cardiomyopathy, anything that increases LV mass will cause more electrical current being pulled towards the left side of the heart, and more voltage going towards the left side of the heart, so it shifts the axis towards the right on ECG. People who have a short and wide build, and the heart is laying more, for lack of a better term, flat on its side, may also have a left axis deviation as well. What causes right axis deviation? Similarly, right ventricular hypertrophy from pulmonary hypertension, pulmonary embolism, so on and so forth, can cause more electrical current and voltage that goes towards the right side of the heart, and that can cause a shift in the axis towards the right side. And then people who are tall and have a narrow build, such as marfanoid people, patients with a body habits that's marfanoid, they may have a right axis deviation on their ECG because the heart is essentially dangling vertically, more vertically than normal in the chest. And then where do you see, in what situation do you see right axis deviation? It's rare in a normal setting. If there is a ventricular arrhythmia that originates from the ventricles, obviously, or let's say the apex for easy understanding, and it's going up and to the right, going from the apex up and to the right towards the base of the heart, you may see a right axis deviation on ECG. But it's typically rare and we don't commonly see it. So let's talk about enlargements. Atrial enlargement, specifically here in this slide. So there are two specific leads that I look at for atrial enlargements. The first lead that I look at is limb lead 2. Limb lead 2 sits right on top of the atria, so it's easy to use that and look at the P-wave morphology to see if there's any abnormality. So what you typically see in limb lead 2 is the image on the left shown, which shows a notched P-wave. So if you would imagine that the P-wave is split into half, and the first half of the P-wave represents right atrial depolarization, and the second half of the P-wave represents left atrial depolarization, because if you remember, there's a Bachmann bundle that goes from the right atrium to the left atrium. And there's atrial enlargement, then there's a delay in conduction from the right to the left, or generally there's a delay in conduction as the electrical current has to travel further down the atria to reach the AV node, then the P wave can be widened and it can have a notch within it as well. So that's what I look at first, because you can see if the P wave is large, if it's small, if it's peaked, if it has a notching in it, and then you should look at V1. So I think I misspoke earlier and I said limb lead 2 sits on top of the atria. I meant V1 sits on top of the atria, but limb lead 2 is in the direction of the net direction of electrical current going down into the left. So then I look at limb lead 1, V1, and I look at the P wave to see if it's biphasic. This image that I've put on the right side of the screen is just the heart flipped on the other side, because one atria looks larger than the other, so I photoshopped it and flipped it to make it look like there's left atrial enlargement here and it's right atrial enlargement here, so don't get mixed up or confused by the aorta coming out the wrong side. But essentially, if we say that the P wave is split into two, and the first half of the P wave represents right atrial depolarization, and the second half of the P wave represents left atrial depolarization, then this model makes sense over here. If the first component of the P wave, of the biphasic P wave, is larger than the terminal portion of the biphasic P wave, then this is probably right atrial enlargement. If the terminal portion of the biphasic P wave is larger than the first portion of the biphasic P wave, then this is probably left atrial enlargement, because as we say, if we travel along the time axis, if the first part of that P wave is larger, that represents right atrial enlargement. The second half represents left atrial enlargement. So depending on which part of that P wave, of that biphasic P wave, is larger, can give us some clues about which atrium is larger. These are all suggestive, and there's a diagnostic criteria in terms of how deep it should be or how wide it should be. It's not very important, and I haven't put it in this lecture series, but these are all suggestive essentially of left atrial enlargement. Left ventricular hypertrophy. There are multiple different criteria to determining left ventricular hypertrophy. I think one of the more popular ones is the Sokolow-Lyon criteria, the voltage criteria. And that says that essentially if you have deep S waves in V1 and you have tall R waves in V5 and 6 greater than 35 millimeters in height. So if you add the depth of the S wave in V1 and the height of the R wave in V5 and 6, and it's more than 35 millimeters, and then you have some of the other additional criteria, then this is suggestive of left ventricular hypertrophy. So it's nothing to memorize. If you think about it conceptually, if the left side of the heart is hypertrophied, and again, there's more electrical current being pulled towards the left side of the heart, there's more voltage towards the left side of the heart as compared to the right side, your voltage on your ECG, which is the y-axis, will be greater on the left-sided leads. So V5, V6, V4, 5, 6 will have greater voltage in the R wave, because the electrical current is traveling toward those leads with greater force. So you have taller R waves in V4, 5, 6. And V1 and V2, which are sitting on the right side, see all of that electrical current going away from them with great force, so they have deep S waves. So if you think about it conceptually in terms of where the electrical current is going and where it's coming from, you don't have to memorize exactly what findings you have. You may need to memorize a couple numbers here and there, but not, was it the depth of the S wave or the height of the R wave? So the bottom line again, the increased R wave amplitude in the left-sided leads, 1, AVL, V4, V5, V6, and the increase in S wave depth on the right-sided leads are what you look at for left ventricular hypertrophy. There are many other criteria as well. This is just one of them. Right ventricular hypertrophy, the criteria is a little bit less, definitive here, But essentially it's flipped. It's the other way around. So instead of having, if you remember looking at our normal R wave progression, we said that V1 and V2 sitting on the right side, especially V1, sees the net direction of current of the heart going away from it. So it gives you a negative deflection because it's going away from it. And V5 and 6 see the net direction of current coming towards it, so it gives you a positive deflection. This is a normal R wave progression. So if you have RV hypertrophy and electrical current is being shifted towards the right, and the axis has now shifted towards the right because of that hypertrophy, and more voltage towards the right side, then your R wave progression is going to be flipped, if you think of it that way. So you'll see a dominant R wave in V1. You may see a dominant S wave in V5 and 6. So that R wave progression is flipped, essentially. With it, again, as I mentioned, you may see right axis deviation. You may see signs of RV strain on right-sided leads. So you'll see T wave inversions and ST depressions. This finding here, this is just RV strain pattern. This is not ischemic pattern. All right, so the QT interval, we talked about the QT interval previously, and this is a little bit more detail into that. The QT interval we said is, obviously starts with the Q wave and ends with the T wave, and it's the duration in which the actual ventricular depolarization and repolarization and the ventricular contraction and ejection of blood occurs during this QT interval. QT intervals can trigger arrhythmias if they're prolonged, such as torsade de Pointes. There are multiple causes for long QT syndromes. The genetic causes are the Romano-Ward syndrome and Jervell-Lang-Nielsen syndrome. So typically the way that these show up on the boards is they'll say that somebody has a history of sudden cardiac death and that have sensory neural hearing loss. There are imbalances of electrolytes such as hypokalemia, hypomagnesemia, hypocalcemia. These can cause prolonged QT. So the way I think about these is you don't have enough electrolytes, hypo, and therefore you cannot conduct depolarization and repolarization effectively in a time-wise fashion. So therefore you have a prolongation of your QT. Drugs such as antiarrhythmics, macrolide antibiotics, tricyclic antidepressants, antiemetics like ondansetron, Reglan, all of them can really do it. And then your atypical antipsychotics such as quetiapine, all of these can also prolong the QT. So you have to be careful, especially if they have had a torsade de Pointes in the past or prolonged QT at baseline. You should be very careful prescribing these medications. Antiarrhythmics, you may wonder, well, I thought they were supposed to prevent arrhythmia. How do they prolong the QT and lead to arrhythmia? Some antiarrhythmics work by increasing the repolarization time, and that's how they work. So if you're increasing the repolarization time, you're going to essentially effectively prolong the QT as well. Examples of those would be dofetilide, for example, or sotalol. So corrected QTC. So the QT interval is obviously rate dependent. The faster the heart rate, the QT will look shorter. The slower the heart rate, it may look longer. So we have to correct the QTC for rate. There are two ways to do it. Method number one is using the Bizet's formula to actually calculate the QTC. So that's typically the measured QT. You actually count the small boxes and get the timing off of that, how many milliseconds it is in duration, the QT, over the square root of the R to R interval. So that same beat, you measure from one R to the next R, essentially, and you take the square root of that. Method number two, and this is an equation that you should probably know. It's good to know. There are online calculators, however, that help you with calculating it when you're on your rotations. Method number two is by estimation. So QT interval should be, if you were to eyeball it on EKG, should be less than half of the R to R interval. So this is only accurate, obviously, if the heart rate is not too fast, it's less than 80. You should also know that once your heart rate is less than 60, your calculated QTC, your corrected QTC is not accurate. So sometimes we go off of just the QT interval if the heart rate is less than 60. In normal, QTC is somewhere less than 0.45 seconds, 0.44 seconds, depends what text you read. And if repolarization is delayed long enough, you may see a U wave after the T wave. And again, it's alphabetical, P, Q, R, S, T, and then U wave if repolarization is prolonged enough or delayed enough. All right, let's talk about ischemic changes on ECG. This is the coronary anatomy. I'm not going to go over this because you've had enough of this in your anatomy class, most likely. But it's important to know the territories of the blood vessels because you'll have ECG changes and they may ask you which blood vessel is the culprit for this ST elevation MI. So you need to be able to correlate which walls of the heart are being fed by which vessels. So some definitions, reversible ischemia or ischemia, meaning it's reversible and it's not infarcted yet, can show itself through transient T wave inversions and transient ST depression. So the key word there is transient, and it resolves. You may not even see any ST segment depressions or T wave inversions. And then once an infarction occurs, you can have either a subendocardial infarction or a transmural infarction. And these are some somewhat older terminology, and we don't look at it as much in this way anymore, but just for the sake of simplifying things for this lecture, whenever you have a subendocardial infarction and it's not transmural, meaning through the entire thickness of the heart muscle, this is called an NSTEMI or a non-ST elevation myocardial infarction, meaning that the ST segments are not elevated on ECG. That could mean that they're either depressed or there are no ST changes. So they could either be depressed and there are T wave inversions or none at all. If you have these sort of changes on EKG, these are not really localizable to where the territory of the infarction is. The only ST changes that you can localize to a territory of a vessel are ST elevations. So that's the next one, transmural infarction, typically referred to as a ST elevation myocardial infarction. This is an acute plaque rupture that causes this myocardial infarction, and that's why I sort of say that the terminology of subendocardial infarction and transmural infarction are sort of older terminology, but you need to know that a STEMI is an acute plaque rupture, that a clot forms once the plaque ruptures. It's unstable, a clot forms on top of it and acutely thromboses off the vessel and causes myocardial infarction. And again, ST elevations can be localized to the culprit coronary artery, typically on the ECG. And then one quick teaching point here that I think sometimes can show up on a board exam or some sort of an exam as a distractor, and not so much be anything that's necessarily the patient needs to be treated as an infarction, is Prinzmetal or variant angina. And this is due to coronary vasospasm, and it presents with pain during rest, or it could be with exertion. There may be ST elevations on myocardial infarction, so as soon as you look at the EKG, you may say that this patient is having a STEMI, but the coronaries, there is no thrombus, there is no acute occlusion, and it's vasospasm. The enzymes will most of the time not be elevated because that is not an infarction, and it's angina, and it's due to vasospasm. The other distractor answer is called Ludwig's angina. I'm not sure if I mentioned that later on in the PowerPoint, but Ludwig's angina is actually an inflammation and cellulitis of the floor of the mouth, and that can also be used as a distractor answer on the exams. It has nothing to do with the heart. So let's talk more about Q waves. I mentioned that whenever we have a lowercase q, means that it's normal, and when we use an uppercase q, it means that it's abnormal. Except in this situation, in the beginning of a sentence, I guess it's capitalized grammatically to make it grammatically correct. But a Q wave represents normal left to right depolarization of the septum. Again, we mentioned that the septum is depolarized from a left to right fashion because the left bundle gives off Purkinje fibers starting at the base of the heart, whereas the right bundle starts giving off Purkinje fibers starting at the apex. So left to right depolarization of the septum, and septal Q waves, lowercase q waves, these are normal. They're seen in the left-sided leads, as I mentioned previously, in 1, AVL, V4, 5, and 6. If you see a small, tiny Q wave, this is normal. They're typically less than 2 millimeters in depth, and also less than 1 millimeter in width or time, if you would. Pathologic Q waves, large, capitalized Q wave, these are greater than 1 millimeter in width, greater than 0.04 seconds, or they're greater than 2 millimeters in depth, or greater than 1/3 of the height of the QRS complex that they're attached to. So these are significant. Typically, you can't miss it. And this signifies that there is current or prior myocardial infarction. And you sometimes may hear the term, the patient is queuing out, meaning that they had an infarction that's completed itself and now there are Q waves forming. So where is the infarct? This is a chart that oftentimes I see people utilizing to try to learn the territories of the vessels. And to be honest with you, I don't like to memorize, I like to conceptualize. So if we actually think about where the ST segment changes are in an ST segment elevation, myocardial infarction, we don't ever have to memorize that chart. So let's go through that very quickly. So if you have ST elevations in 2, 3 AVF, think about where those leads are pointing to. 2 is down and to the left, 3 is down and to the right, and AVF is straight down towards the feet. So if you have ST elevations in 2, 3 AVF, you probably have an inferior infarction. If you have ST elevations in limb lead 1, AVL, V4, 5, V6, these are all pointing towards the left side of the chest. You have ST elevations there, you probably have a lateral MI. If you have ST elevations in 2, 3, 4, for example, you should think about an anterior myocardial infarction. A posterior MI and changes seen in V1 is a little bit different. That's coming up, and I'll show you that, a couple ECGs of that, of a posterior MI. That's one that sometimes is easily missed. And the other thing that's important to know is that the leads that are directly opposite to the area of infarction or damage, these are called the reciprocal leads. And so these oftentimes show the opposite of the deflections that you see where the infarction is. So you can use this to essentially confirm or reconfirm the location of the infarct. So I'll give you an example. If the patient has ST elevations in 2, 3 AVF, V1, V2, V3 is generally in the opposite direction of the inferior leads, although it's not an exact 180. It's generally pointing in the opposite direction of the inferior leads. So you may see T-wave inversions and ST depressions in those anterior leads. So you can use this to help you determine where the location of the infarct is. Could there be an end-STEMI elsewhere? That's oftentimes, the question that students ask me, but you have to keep in mind that these are reciprocal changes, as we call them. So what is the definition of a STEMI? In a patient with no left bundle branch block or pace rhythm, who's a male greater than the age of 40, 2 millimeter ST elevation in V2 and 3, or 1 millimeter ST elevation in any other lead. If they are less than the age of 40, then 2.5 millimeter ST elevation, so the criteria is a little bit more forgiving in V2 and 3, and 1 millimeter in any other lead. For females, 1.5 millimeter ST elevations in V2 to 3, and 1 millimeter in the other leads. It's important, however, to note that these changes must be seen in 2 or more contiguous leads. So if you have an ST elevation in V2 and another one in V6, it's not contiguous, so it doesn't make sense. So it has to be V2, 3, 4. Limb lead, 2, 3 AVF. So it has to be in 2 or more contiguous leads to raise your suspicion for myocardial infarction. A quick word on inferior wall MI. So inferior wall MI, obviously 2-3 AVF, downward pointing leads will have ST elevations. You may see the reciprocal ST depressions, as I mentioned, in V1 through 6, AVR, AVL, limb lead 1. These are all pointing away from the inferior leads. And so whenever you have a patient who has a suspected inferior wall MI, you should do a right-sided ECG, where you take the precordial leads from the left side of the chest and you put them on the right side of the chest. And if they have ST elevations on the right-sided ECG leads, V4, 5, and 6 along the right side of the chest, this suggests that there's an RV infarction as well, and that perhaps the occlusion in the RCA, right coronary artery, if it is a dominant right coronary artery, um, uh, then the occlusion is probably more proximal and it's affecting the right ventricle as well, and there's an RV infarct. Um, and so this is important because oftentimes the primary treatment for myocardial infarction is pain control, morphine, oxygen, nitrates, and aspirin. And if the right ventricle is preload dependent, meaning that it needs good central venous blood pressure support to be able to push the blood through the right ventricle to the lungs and to the left side of the heart, and now you've caused an infarct, and the RV is failing now, and you give a nitrate, which is a venodilator, and reduces central venous pressure and reduces blood pressure, then you're worsening the RV failure, the right ventricular failure, and the transit of blood from the right side of the heart to the left side of the heart. So they can get very hypotensive and they can die. So that's the importance of determining if there is an RV infarct. If they're hypotensive, they're a little bradycardic, I would be very careful with giving nitrates. So anterior and posterior infarctions. This is a pictorial depiction of a left ventricle in a cross section here. This is the posterior wall, this is the anterior wall, and conduction goes subendocardially to epicardial tissue. So if you were here in this image, if you were to knock out the anterior wall with a myocardial infarction, the lead on the chest is seeing the electrical current from the posterior wall traveling away from it and not being negated by electrical current that's coming towards it from that anterior wall in a normal situation, then you will see large Q waves. This is a negative deflection in the QRS, and it represents as Q waves. If you, in a posterior infarction, if you were to knock out the posterior wall and the lead only sees the depolarization in the anterior wall coming towards the lead, and there's nothing in the posterior lead to negate it, and it doesn't see anything going away from it from the posterior lead, then you have a positive deflection, these R waves, large R waves, and then the ST depressions and ST elevations are as a result of the repolarization abnormality that happens in a myocardial infarction. And also the electrolyte milieu that causes deflections of electrical waves in an ischemic segment. So there is no, although there's no very good understanding of why we have ST elevations, it's thought to be either repolarization abnormality in a myocardial infarction or that the baseline shifts up or down, making the segment look elevated or depressed. So whenever you have the large R waves in V1, which is directly over the posterior wall of the heart, if you would, you should do what's called a mirror test. So you take the ECG strip or the 12-lead EKG, and you either look at it in the mirror or you flip it upside down and look at it through a light, and you can see that the large R waves in V1 become Q waves, and the ST segment depressions become ST segment elevations. So it looks like an anterior infarction. So when you do the flip mirror test and it looks like a anterior infarction, then it is definitely a posterior infarction. So these are some things to keep in mind. So these were the criteria that I mentioned for patients who do not have a left bundle branch block or ventricular pace rhythm. Now, what if they have a known left bundle branch block or ventricular pace rhythm, and they present with chest pain. It's difficult to diagnose an acute myocardial infarction, but we have a set of criteria called the Scarbosa criteria that's based on statistics and looking at changes. So what we're looking at here is concordance and discordance of the ST segments and the QRS complexes. Concordance meaning that they go in the same direction. Discordance means that they're going in the opposite direction. So looking at the first criteria, if there is an ST elevation greater than 1 millimeter in a lead with a positive QRS complex, so there's concordance. The ST segment is going up and the QRS is also going up. This is 5 points. If the ST elevation, if there's ST elevation greater than 5 millimeters in a lead with a negative QRS, so discordant ST and QRS, this is 2 points. So this is the middle image here. There's a negative QRS and there's an ST elevation, so it's discordant and it's greater than 5 millimeters. This gives you 2 points. And then finally, if there's an ST depression more than 1 millimeter in V1 or V2 or V3, this is with a concordant QRS complex. This is shown on the third image here, the third wave. This is worth 3 points. So if you have 3 or more points, it's a 90% specificity for a ST elevation MI in somebody with a known left bundle or ventricular pace rhythm who presents in the right clinical setting, so in chest pain. That's typical anginal pain, let's say, and that have risk factors. The third criteria is sensitive, but it's not very specific for ischemia and left bundle, but it is associated with worse prognosis, so that is something to keep in mind. So there's a little bit more to the ST segment elevations, and that's the ST segment morphology, because as you probably know, J point elevation or ST elevation has many, many causes, and not all of it is due to an infarction. So we look at the morphology. If we look at the cartoon image on the left side here, the J point, if you were to draw a line, this dotted line here from the J point, which is where the ST segment meets the end of the S wave, and you draw that line up to the top of the T wave, if your ST segment is concave and looks like a smiley face, then this is a strain pattern. Okay, with the exception of the inferior leads, because most times you'll see this sort of strain pattern looking concave ST elevations in the inferior leads with an inferior MI. This is talking about the anterior waves here, or the anterior leads rather. If you were to draw a line from the J point all the way to the apex and the ST segment is concave and it looks like a hump like this and a sad face, then this is probably an ST elevation myocardial infarction in the right clinical setting. This is what we call tombstoning. So let's go ahead and do a practice 12-lead ECG. So I'll give you guys a moment to pause the video and go through this. I want you to read the EKG and go through rhythm, rate, access, and there's an obvious finding on here, so it's okay to jump to that and say what the obvious finding is, but also go ahead and look for enlargements and hypertrophies and your segments and intervals if there is any prolongation anywhere. But remember, rhythm, rate, access. All right, now hopefully you've had a minute to pause the video and think about it. So how I typically read a 12-lead ECG is I look at limb lead 2 first, because from limb lead 2 I can gather the majority of the information that I need regarding rhythm, rate, and access. So we said that limb lead 2 and limb lead 1 are the best leads to use for access, but although traditionally we've been taught to use limb lead 1 and AVF. So let's use limb lead 2 for now. If our QRS is a positive deflection in limb lead 2, we can say that the net direction of current is down and to the left, the way that the heart sits within the chest. So this is probably a normal access. However, looking at AVF, we see that the QRS is borderline. It's a little bit more negative than it is positive in AVF. So this could be borderline left axis deviation, maybe at 0.90 or 0.30 degrees. And then after that, I look at so that was our axis, obviously, but looking at our rhythm, you look for the P wave, and we see a nice small P wave here, followed by QRS with every beat and a T wave that follows that. So this is a normal sinus rhythm. And then next, I calculate the rate. So you can go ahead and do the counting method, the counting the boxes method, since this is a regular rhythm and it's not irregular. So we can use this R wave, for example, that falls in a dark line, and we can count 300, 150, 100, 75, or 70, 75, and then 60. So it's somewhere between 60 and 75 is our rate here. And then we talked about our axis and how it's positive in limb lead 2 and slightly negative in AVF, so it makes us think that there is a slight left axis deviation, although it's within a normal quadrant most likely. Then we jump to the obvious thing here on this ECG, and that's that there are ST elevations in the anterior lateral leads. So in V2, V3, V4, V5, and 6, there are ST elevations. They're convex in morphology. They're the tombstoning ST elevations that you typically see. Also, AVL and lead 1 are elevated as well, which confirms that there is lateral wall involvement for sure. And then look at lead 3 and AVF. There's a slight depression here, and again, and you know, this is essentially reciprocal change, as we said before. It's not that there's an end stemming in the inferior wall, but these are reciprocal changes to the anterolateral ST elevation MI. The heart rate here says 80. I've yet to fix this for the past 5 years on this PowerPoint for some reason. All right, let's take a quick break and we'll come back in the next section and talk about arrhythmias, which is the most exciting part.